this is really the first time that we've had a significant group of people with vascular EDS here. For those of you with Marfan syndrome, you look around the room and you say, ah, yes, I know this person, I know this person, I know this person. And the question is, who? Who is it in the audience that has vascular EDS? And how can you tell? And why do we have this group included under the umbrella of the Marfan syndrome, Marfan Foundation? Well, I think there are many things that are very much apparent, and it's the vascular component of things that are really in common. It's a little bit different, the kinds of things that happen to people with vascular EDS. It's much less predictable, but you'll see a few things. And I wanted to introduce you to people so that when you look around, you can tell, perhaps you'll see some of the people and say, ah, yes, you must be in the vascular EDS group. And while they're learning about, ah, yes, you're in the Marfan group. But the thing that's been remarkable about it is that there's a lot of there's enough commonality that conversations are beginning and people are talking about what's going on. So, which button is forward? The green button, the big green button? Yeah. So this is a composite. You heard Kathy Bowen talk last night. She's the founder of the EDS Today group. And this is a poster that she put together of people who were in the community and who had vascular EDS. You heard her talk about her son Dave, who's right in the middle and the bottom. You get a sense that there are some people in here who will be quite recognizable, and you might be able to pick them out on the bus or as you walk back and forth here and things like that. So this is a condition which was probably first recognized in the 1930s by George Sack, who was a cardiologist in Germany, and he called the condition. He recognized there were people who had spontaneous ruptures of arteries. He wasn't sure whether they were aneurysms, and it was called status dysvascularis. In the mid-1960s, a British surgeon, Byers, recognized that among people that were thought to have a diagnosis of a form of Ehlers-Danlos syndrome, that is, they had some features of Ehlers-Danlos syndrome, like joint hypermobility and unusual skin, or that was a little unusual, that there was a specific subset, and they had aortic or vascular disease. They bruised very easily, and they were clearly different from people who had the ordinary kinds of Ehlers-Danlos syndrome. And when Peter Byton wrote his summary, and for those of you who know the name Byton as Byton scores, that is how many joints can you extend more than usual. It's the same Peter Byton as a geneticist who spent his entire working career in South Africa. But he introduced a typing system for Ehlers-Danlos syndrome, and the vascular form is the dysvascularis, and then the vascular form that Byers talked about became Ehlers-Danlos syndrome type 4. And that persisted for a long time until fairly recently it became renamed as vascular Ehlers-Danlos syndrome, which sort of underrepresents the kinds of things that can happen to people because bowel rupture is one of the things that occurs. It's something that's not seen in Marfan syndrome, but is characteristic here. So let's talk a little bit about the differences. So Marfan syndrome has a prevalence in the population of about 1 in 10,000 people. I come here, people tell me it's always 1 in 5,000 people. And I think as time goes on, it's going to become 1 in 100. And, and depending on what we do with the water, it's going to be maybe different. But, and of course, climate change. But, so don't walk outside here. And vascular EDS, the prevalence is not known because it's not as readily, the diagnosis is not as readily made. We think it's somewhere between 1 in 40,000 and 1 in a couple of 100,000 in the population. I think it's probably closer to the lower number. So it's about 1/4 the frequency of Marfan syndrome, perhaps even a little less. There's one gene that has mutations that cause Marfan syndrome, fibrillin-1, that you're familiar with. The gene that causes all forms of vascular Ehlers-Danlos syndrome is the COL3A1 gene. That's a pet name. We call it the type 3 collagen gene. Genetic heterogeneity means, are there other genes that cause Marfan syndrome? And the answer is no, but what you've recognized and what Diana showed you so clearly is that there are other genes that cause Marfan-like conditions. For vascular Ehlers-Danlos syndrome, the clinical picture sometimes overlaps with some of the forms of Loeys-Dietz syndrome, and the diagnosis can be difficult to make, even for very experienced conditions. But the definition of vascular EDS really is a mutation in a type 3 collagen gene. Is there clinical heterogeneity? You know, this means, does everybody who has Marfan syndrome look the same and have the same complications at the same time? And you can answer that question by simply looking around the room and talking to people, and you know the answer is absolutely there's heterogeneity. There are people who have, as Diana pointed out, have things happening very early on, and there are some people who get through an entire lifespan of 75 years and don't have complications. The same is true for vascular Ehlers-Danlos syndrome. So almost always we start with people who have the most severe clinical pictures, and that's what we think about as the condition. And as we do more and more testing, we find people who have very different forms. They're both autosomal dominant, which means that they're transmitted through generations in the family. And if that it's equal opportunity employers, that males and females, men and women, boys and girls, will have the same risk of having the condition. And if you have it, you have a 50% chance of transmitting it with each pregnancy. Is there a care plan for Marfan syndrome? It's actually pretty clear. You know, we know what to do. We know how to follow people. And for people with vascular EDS, it's not so clear. It's less predictable about when things are going to happen, and so we're not sure exactly how we do things. Do we monitor? What do we monitor? And things of that sort. Surgical intervention, in Marfan syndrome, it's very clear. I'm talking with some of the people about what's been the major driver for the increased lifespan in Marfan syndrome. I think one of the biggest things is actually preventive surgical management, that we hope that drug management will take its place as we go along. For vascular EDS, surgical intervention is fraught in many instances because the tissues are very soft and sometimes are described as sewing into wet blotting paper. So it's problematic. Surveillance, we know what we do in people with Marfan syndrome. We're uncertain about surveillance in people with vascular Ehlers-Danlos syndrome. In an organized peer group, look around. We have a very organized peer group right here. For vascular EDS, it's been a problem. Kathy Bowen's group online has been extremely effective in connecting people, but it's virtual. And people come, and many people who have talked to each other for years over the virtual networks have never met. And so coming to a place like this represents a very different opportunity and a different chance. And today we have EDS Today as one, and a new vascular EDS collaborative group, which brings together a number of the smaller foundations, and in addition to that, the Ehlers-Danlos Society and the Marfan Foundation are all beginning to create organized peer groups for this group. So I just want to talk to you and introduce you to a few people. These are people that we've seen in Seattle. Darren is pictured there on the left. He had a clubfoot at birth, which is one of the cardinal signs. He had a bowel rupture at the age of 6. He had a tibial bleed when he was 12. He had keratoconus, or thinning of the corneas, when he was 22 and had corneal transplantation. He had a stroke because of a carotid dissection when he was 28. He had a brachial artery tear. He was bowling and just tore his brachial artery. And then at 35, he died because he had a colon rupture and sepsis and died from that. Here's his family. His mom died at the age of 34 as a result of a uterine rupture during the delivery of his younger sister, who's the one on the right. Darren is the, what is it? Does that make, yeah, so Darren is, I'm sorry. I can point, it's really great pointing here on the front thing. It works really well, but I'm looking for it, it's not up there, and unfortunately there are 2 screens, but so Darren is this one here, Darren is the same one over there. And then his 2 daughters are pictured on the lower left when they were, I think, 5 and 3. The affected one died at the age of 41, but she had had a normal child that we were able to determine by prenatal diagnosis. Here's one of the first patients that I saw, Nan. She was very fragile at birth. She bruised very easily, which is one of the cardinal signs that we see. At 12, this is her picture at 12. in the middle of the top row. At 26, you can see there's a picture, and you can just see all the veins on her chest and her abdomen. And that's one of the typical features, the thin skin and the bruisability. You can see her hands on the lower right. It looks like those look like the hands of somebody who's either doing a lot of dishes without gloves on, or is really old. And that picture was taken when she was in her 20s. And that's a feature called acrogyria, or aging of the distal parts. And that's one of the features that happens that we see with people, but it's only a small subset. Here's a pedigree, or a family tree, and you can see the young woman who has the arrow at the bottom, the darkened circle, came to clinical attention because she'd had a headache that persisted. When she was imaged, she had a diminished flow through one vertebral artery. It wasn't clear whether she had a new dissection or whether it was just an incidental finding. She was studied genetically, had a mutation in the COL3A1 gene, and then the family came to see us in Seattle, and her father came with, and as did her grandfather, who at the time was 72. Her father had been well, had had no complications, tore a calf muscle descending Mount Rainier at the age of 40. The dad had had bilateral knee replacements at 70 and had a heart attack at 72, but was well at 80. So this represents the full range of clinical presentations, and it's very striking. And here you can see that, as I said, if you look, we see when we first start to recognize these clinical conditions, we really concentrate on seeing people at the right hand of the severity spectrum, so those people who are on the right-hand side. And as we see more and more people, we recognize people who are not necessarily clinically affected. So I've seen, a fair number of people with this condition, and there are people when I have a mutation in my hand and I walk into the room, I cannot make a clinical diagnosis. That is, I can't tell the difference between whether they're affected or not affected. And so, we worry about people who in the general community can't make this diagnosis or don't make it. But if I can't make the diagnosis in the absence, where do we go and how do we do that? And so those are one of the things that we need to talk about. So this is a group of it's actually the Danish group at a meeting in Copenhagen of people with vascular Ehlers-Danlos syndrome. And when you look at the pictures, you can see that there are clear features that you would look at, that they look like some of the people that you just saw. But the two women who are second from the right and third from the right both have very mild forms of vascular Ehlers-Danlos syndrome, and I didn't know whether they were affected or not. They had to tell me that they had mutations in the gene. The woman on the far right is in her early 30s. She looks like she could be 60, and that's one of the premature aging kinds of features that we see with this condition as well. So how do we make the diagnosis? We use family history is very important. Clubfoot at birth and congenital hip dislocation at birth are important. Hypermobility of small and joints and sometimes large joints, and critically, bruising in childhood. And it's one of the things that is missed, or it's recognized. Kids go to the family doctor, they initiate a workup, they stop after they look at clotting factors and platelets, and don't go on to the next set of looking for genetic causes. Spontaneous pneumothorax, tendon and muscle rupture in the late teens can be present. Gingival recession and gingival fragility, so bleeding when people brush their teeth. Early onset of varicose veins, and then about a quarter of people have a bowel rupture, which is usually in the sigmoid colon, so it's appendicitis on the left or diverticulitis on the left, it seems like. Aneurysms, dissections, ruptures, and then some people have a characteristic facial feature that you can see. And one of the interesting questions is, do you sleep with your eyes open? Well, this is a question you yourself can't answer, usually, but the parent or your sleeping partner often sees it, and it's one of the things that's there very early on. They recognize it in the near newborns, and it's because they don't get their lower lid fully up. And so one of the features that you see with people is that they actually have large appearing eyes, and the lower lid doesn't close fully. On the clinical examination, I know that you don't examine people except those people that you see on the bus. You know, when you see, oh, yes, you have Marfan syndrome. And you have to think, you know, you're doing a clinical examination. What are you doing? What are you looking at? Well, sometimes you may be adventurous enough to go shake their hand. Usually not. So you do a physical exam by observation. So for this group, we always shake their hands. Does the skin seem thin or old? Are the joints lax and soft? Can you see blood vessels on the skin? Are the fingers tapered? Is there wrinkling in the palms and fingers? So all things that, you know, when your doctor examines you, usually don't do. I mean, how many times does your doctor shake your hand when you walk in the door? Not very often, right? How often do they look at hands? Not very often. You look at the face and you can see here a couple of people who you'd say, you know, they look different to me. And how can you characterize it? Is the hair fine and thin nose, thin lips, visible veins on the forehead over here, gingival recession, and eyes recessed or prominent, and then sometimes pigmentation of the skin. You know, and then you examine the skin, you look at the joints and mobility, and listen for murmurs and bruits or sounds of arteries being restricted. So, and then the diagnostic studies are always the sequence of the COL3A1 gene. When we do sequencing of genes, we do all the vascular genes at the same time because it's cheaper and easier, and we also sometimes, because we're not so good at clinical diagnosis, we'll find people who have other conditions. So we may find people who unexpectedly have Loeys-Dietz, and so forth and so on. And so why do we test? Well, one, it confirms the diagnosis. The second is it gives us information about natural history. And just as Diana pointed out, for many of the people that they see with mutations in the other genes that give aneurysms, the same kind of information emerges from sequence analysis. It allows for family testing and for family planning and even for prenatal diagnosis or pre-implantation diagnosis for people who don't want to get pregnant, who don't want to transmit, and then use of surrogacy if that's an option. So Reed showed you a survival curve this morning that was looked at in the 1970s by Murdoch and Victor McKusick and his colleagues. And if you look, the survival curve that we have doing the studies we do just in assessing what happens is the one on the bottom here. And it's surprisingly like that curve for Marfan syndrome in the 1970s. So that gives us hope that we are going to push that curve to the right. So the other thing that's unusual is on the bottom right hand is a assessment of deaths at early age. And what you see, and if you remember, Kathy had talked about the deaths of the young boys in the population. So those are deaths at particular ages, and you see at the younger ages to the left of the graph on the bottom there that there's a predominance of male deaths. We don't know why. We don't know whether it has to do with gender, hormones. It has to do with gender clearly, but does it have to do with hormones? And if there is, what could we do? What might we do to prevent that and move that curve to the right? So that's a critical question. And these are questions, I remember the time Kathy was standing there and saying, you have to do something about this. Our boys are dying young. And this is the representation of what she was talking about. So survival is affected by mutations and the kinds of things that go wrong. And we have three classes of mutations that we see. On the top line, on the left, are people who have one copy of the gene that has basically gone to sleep. It doesn't work at all. We call them null mutations. The other one works just fine. They just make half the amount. And the survival for them is really very different. Is really very different. And you can see it's way up here at the top. And it's like some of the curves that you saw for some of the mouse strains and some of the ones that were treated. And then the other two, or the other three curves, represent different kinds of mutations. And then we can split out the red curve, which are the most common sorts of mutations, which are substitutions for glycine, which is in every third position along the middle of the molecule, and say, is there a difference among them if we put in a big amino acid or a small amino acid? And the answer is yes, there is. So this gives us predictive value to some extent, although I always have to caution people that these are population curves and they don't tell an individual what the outcome is going to be. So you can't look at that and say, oh yes, I'm going to be here for 53 years and 27 days, which is what people tend to try to do. So a big issue for the families is pregnancy in women. And the traditional talk about this, and Diana talked about pregnancy, is people would be said, don't get pregnant because you will die. And the number of times people get told this is incredible. And if you do get pregnant, terminate the pregnancy or you will die. If you don't terminate the pregnancy, go see someone else because I'm not going to take care of you. So we were very interested in this because this is sort of the, there's a mythology that surrounds all of these genetic conditions, and the mythology derives from places we really don't know about. So Mitzi Murray, who is one of our faculty people and one of our fellows in genetics, undertook a study to look at what really happens with women who get pregnant. And the simple tool that we used was really to ask whether survival was the same for women who had ever been pregnant as opposed to those who had never been pregnant. And the answer was, to the best of our ability of seeing, looking at 300 women who had been pregnant and 300 women who hadn't been pregnant, that the survival curves looked similar. They basically overlapped. Now there are a number of problems in terms of methodology, and can you use this kind of analysis and all kinds of things like that. But this was a very different look at what happens. Clearly they have complications of pregnancy, they can have tissue tear and things of that sort, but it doesn't look like it decreases life expectancy. People do have deaths during pregnancy, but they're pregnant during the time when they're most likely to have complications anyway. So that makes a difference. So we are trying to create care teams, very much like we do for most rare conditions, where the patient and the primary care physician is in the middle, and you have the other people around, and it's an integrative and cooperative network where everybody talks to each other, and you do that. That's our pie in the sky, and if you listen to Katie Wright's stories about making and creating a care team on her blog and on her YouTube things, you'll recognize it's not as simple as we make it out to be. We imagine that everybody out there wants to take care of people with this, and they don't. They're frightened about it, and they're frightened because they think they don't know anything about vascular EDS. But if you listen to the complications we've been talking about, bowel rupture, arterial rupture, they have people with aneurysms in their practice if they're internists. They see people who have diverticular disease and may have bowel rupture. So many of the things that are there are things that are common in their practice. And they have to get used to the idea that they can take care of people who have those kinds of complications, even if they're on this background. There are some special twists that people need to know about. So we identify the mutation, create a care team, a management plan, see if there are lifestyle variations, try to make sure blood pressure is kept there. Surveillance is probably something that's important, and that's the way we do things. So the treatments so far have been largely blood pressure control. Celiprolol was touted very strongly by the French. The most recent studies make it clear that they can't tell whether celiprolol, which is a form of beta blocker, makes a difference in long-term outcome. And then surgical management is different, and there are all kinds of ways that people are beginning to look at to ask what's going on. And for pregnancy, we think that probably the C-section with a C-section is probably better done a little earlier because you avoid uterine rupture and probably other kinds of things. The issues about breastfeeding are unclear. We have a need for education in the medical community. Animal models are now available. Diana's been working on one. Hal's working on a couple. The French group have had some. And they're beginning to look at responses to medications and what kinds of things might be going. Celiprolol in some hands looks like it's a wonder drug, and in others look like it's the worst thing possible to take. So we don't know what the answers are, and hope we'll have them. Effective treatment and surveillance are coming. Family organizations and creating the peer groups that are really essential is vital to this, and having a professional organization that's involved in the care is really very important. And finally, the Vascular EDS Research Collaborative, which is headed by Shireen Shaloub, who's a vascular surgeon with us in Seattle, is now enrolling people for a natural history study, which will also feed into the MAC consortium and also be available for identifying people. We're hoping we'll have more than 1,000 people in it within a year or so that will be available for clinical trials of drugs and drug management and looking at all the other kinds of things. So that's who we are as a vascular EDS community. That's who people are. So when you see them, there's not a secret handshake. You just say, hello, hi, how are you? And they're very nice people. So I recommend them highly. Thanks.